This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 25, Ventilation. And after completing this chapter, you'll be able to understand the formation of acid from respiratory and metabolic mechanisms and physiological pH, three important chemical buffers found in the bloodstream. Respiratory and renal compensation by deriving the acid bicarbonate formula, and acidosis as an imbalance. Respiratory and oxygen transport. Important concepts here. We're going to talk about respirations, oxygen transport, and then carbon dioxide transport. So this is figure 25.1 in your book, the process of respiration. So we essentially start here with inhalation. Oxygen, more oxygen-rich blood or more oxygen-rich air comes in the lungs than is returning. So by diffusion, we get a transfer from an area of higher concentration to an area, since this is the return, lower concentration, and then it goes out into the bloodstream. And the Bohr effect is, as the acidity of the sample changes, the oxygen is offloaded into the cellular tissues. Now they grow hold of it, and vice versa, since their cellular metabolism is CO2. That's kind of like their tailpipe. The red blood cell picks up the CO2 and then moves it back to the alveolar sac again. Once this gets to the lungs, then the exchange occurs and exhalation occurs, or the CO2 is expelled. And that entire process is respiration, both external and internal. Figure 25.2, oxygen movement across the capillary alveolar membrane. Again, it goes from an area of higher concentration to an area of lower concentration, or either way. When we're talking about CO2, this is why this is an area of lower concentration, and the returning supply would be an area of higher concentration. So all these things really do is just kind of balance. The hemoglobin molecule itself is what carries the oxygen, and that's figure 25.3. Figure 25.4. Each red blood cell contains approximately about 270 million hemoglobin molecules. Each hemoglobin molecule can normally bind up to 4 oxygen molecules. And this is 25.4 here, oxygen hemoglobin dissociation curve. And this is the amount of pressure of gas that's actually in the sample. So as long as we get above, say, 60 to 70 here, this is pretty consistent with our pulse oximetry. Now, if we get below 70% saturation, gas pressure isn't that much, and we can no longer trust our finding. So anytime that you get a SAP below 70%, you don't really know how much gas pressure the patient has at the cellular level. And without gas pressure, the gas itself, oxygen or CO2 or whatever gas we're talking about, doesn't have enough push to actually functionally oxygenate things. This is table 25.1, factors that affect the ability to bind oxygen to hemoglobin. And there's two categories here that we should look at. This is increased, and this is decreased. So this right here, these are the things that would decrease the ability to bind oxygen to hemoglobin, and these here would increase the ability to bind oxygen to hemoglobin. So the increase. Let's talk about that first. So if you're alkalotic, alkalosis itself would increase your ability to bind, decrease CO2 to bind, decrease temperature, and decrease 2,3-BPG. Now that stands for 2,3-biphosphogyl, and what that substance is a compound found in the body that enhances the release of oxygen. So if you have a decreased amount of this substance, 2,3-BPG, then you have an increased affinity for oxygen, and vice versa. On the opposite side of this teeter-totter, acidosis will decrease your ability to bind oxygen. Increased CO2 also would decrease it. Increased temperature. And an increased amount of 2,3-BPG. Now, if you'll remember, I said that this compound is found in the bloodstream, and it enhances the release of oxygen. So the more that we get this, the more that we have an increase in the amount of 2,3-BPG, the higher release factor we actually have for the hemoglobin. So that would decrease the amount of binding that actually occurred. Acid-base balance, important concepts. Aerobic and anaerobic metabolism, buffering systems, effects of an acidic environment, acidosis and medication, and acid-base disorders. So first of all, we're going to talk about aerobic and anaerobic metabolism. Now, aerobic metabolism means with oxygen, and with oxygen comes into the cellular environment. We get glycolysis that gives us a little bit of ATP and the production of pyruvic acid. This goes into the mitochondria, and then we make a whole lot more ATP with oxygen. Anaerobic metabolism is without oxygen, and if we'll quickly look here at the difference between these two, we didn't make very much ATP at all. Without oxygen, we can put the cellular environment into a state of essentially cellular bankruptcy by not providing enough energy, because we did go into a without oxygen metabolism. We also get some nasty byproducts from this, which is lactic acid and pyruvic acid. pH scale with common acid base is shown, and I want to remind everybody that this is a logarithmic scale, and what that means is the lower the number gets. Let's just do this in red here really quick. The lower the number gets, the more acidic something is. And the higher something gets, the more alkalotic the substance is. So this is super alkalotic as we go this way, and this is super acidic as we go this way. Very balanced pH or neutral pH is 7.0, and that's pretty much the pH of distilled water. Now we reside 7.35 to 7.45, so in all actuality, we are about right there. And that's us here. If we're out by 1 point in either direction, it is a non-life sustaining pH. The acid bicarbonate reaction, increased ventilation forces this chemical equation to move to the left. Increased production of carbon dioxide and water, which are then removed from the body. Let's kind of talk about this here for a second. So bicarbonate is HCO3 with a negative on it. And very simply, the definition of pH is the amount of hydrogen ion concentration in the blood. Now, the only thing that occurs is this is a very weak base. It likes to pick things up. So it's going to pick up those extra hydrogen molecules. This is carbonic acid. H2CO3. The carbonic acid bicarbonic anhydrase, which is on the red blood cell, is broken down into CO2 plus H2O. and this is a reversible reaction, which means that your body has plenty of CO2 and water. If it needed to make acid because you were alkalotic, very simply it could throw it in the reverse direction. So this is a completely reversible reaction formula here that we're looking at. Assessment of oxygenation and ventilation. Techniques that we have to perform this is pulse oximetry, capnography, Co-Oximetry, and arterial blood gases. Just a brief overview here really quick. Pulse oximetry may display a numerical indicator of SpO2 or a waveform display of SpO2. Both of them are listed here on this picture, and this is 25/7 in your book. That this is the heart rate, and this is the pulse oximetry, and then this here is a waveform. Now, the nice thing about seeing the waveform is if I got good markings, then I can kind of trust the numbers that I'm coming up with. But if I just have not so good markings, then I can't trust it. Or vice versa, if you're only dealing with one of these devices, if the pulse isn't matching what I have on the monitor, then there's some kind of mismatch between what I'm seeing in the finger and what I'm seeing on the EKG. So just be aware of that. You may get some erroneous readings. That's one of the ways to get erroneous readings. Normal pulse oximetry waveform is shown here, and this is figure 25/8. That would be this guy here. And then this is an abnormal pulse oximetry waveform. This reading I would not trust because it has no spikes here at all. And I don't know, without those spikes like so, I don't know whether or not to trust this number. Mainstream versus side stream sampling. When we look at mainstream capnography, it involves placing a sensor in line with the exhaled airstream and can only be used in intubated patients, and that would be what we show here on the side. This would be mainstream. Side stream capnography involves taking a sample of the exhaled air by aspirating a small amount of it in the exhaled airstream, either by endotracheal tube or through the use of a modified nasal cannula. And that's what this here is. Kind of takes a sample, either, generally we have them breathe out their mouth. This is a little cup. The little cup looks like this, and it'll catch their expired CO2, and then the machine will read the amount of gas that it actually finds. This is a capnographic waveform. Please take a look at the, you have a diagnostics section that will be coming up here for long, but it'll explain this in full detail. But today we're just going to take a look at the waveform here just a little bit. And this is 25/12 in your book. And if we think about this as an exhalation or a reversed inhalation, now we're used to seeing things all the time on the monitor that do this, but this right here is when you start to expire air, and the CO2 slowly rises until it reaches this peak amount, and that would be B here, measured Untitled CO2. And this is what number it comes up with. So let's give it a normal number here. 35 to 45 is the normal numbers to come up with. Let's say that this number here, where I put that circle, was 40. That's what would read on your monitor. And then as your inspiration occurs, it kind of bottoms this out because the machine doesn't see any more CO2. So this is kind of a reverse inhalation here, or what we normally would see on the pleura or pleth monitors that would show us those actual waveforms. Be aware at this point as well that if we see respiratory diseases, we can mark them out on the capnography by identifying and understanding this this entire waveform. So one of the things that I'll plant the seeds for now, a shark fin is the trapping of air. So what that means is air got in, but it is very difficult to get out. And took a long time, and these might even elongate as well. This shark fin means bronchospasm. Co-Oximetry, or carboxymethemoglobin, or carboxyhemoglobin, CO, and methemoglobin levels, they're obtained in the hospital using a sample of either arterial or venous blood and require a special co-oximeter. More recently, non-invasive co-oximeters have developed non-invasive measures of SpO2 and COH and methemoglobin technology. So we can actually look at these in the field. LifePak 15s have an option to where you can look at their carboxyhemoglobin, which would be the amount of CO that is on their hemoglobin molecule, or methemoglobin. Now, methemoglobin, very simply, can also be generated by pharmaceuticals and drugs and medications. One of the mechanisms that do this is the Massimo Rad 57. Clinical applications of this are very simply, we can determine whether or not they have CO poisoning or not. If you've ever had that patient where you're trying to oxygenate them and they may have been in a fire or something, and you did not have one of these devices. An example of this, let's say that this said 18% and the pulse ox said 100. We take 18 away from 100, we get 82%. So if you saw somebody with a pulse oximetry of 82%, you would be kind of alarmed. Well, I will assure you, if you have CO locked down on the hemoglobin molecule and it sees 18% of the sample, that hemoglobin does not have access to oxygen. So to the patient's perspective at the cellular level, they're at 82%. These are arterial blood gases, and whenever we've talked about these before in various slide sets. We'll talk about these more in diagnostic as well. But pH is the hydrogen ion concentration. Anything below 7.35 is acidic. Anything above 7.45 is alkalotic. CO less than 35 would mean that they are hypocapnic. Greater than 45, greater than 45, my apologies, would make them hypercapnic, which means they have a high amount of CO2. And it's just like anything. You have a high amount of CO2 and a high amount of building blocks. Very simply, you can build more acids. In this case here, we would be concerned with carbonic acid. PO2 level, 70 to 100 millimeters of mercury. We like to have people's SpO2, or their oxygen saturation, at about 94, 95 would be ideal. Greater than 94%, because then they're oxygenated, or what we would consider oxygenated. The PO2 is the amount of gas pressure that's in the arterial sample, or the amount of gas that's actually there. So below 70 is hypoxic, and this refers back to that oxygen hemoglobin dissociation curve. And over 100 is hyperoxic, and we know that oxygen is kind of a free radical, and it can do damaging things to the cellular environment. Last but not least here, the bicarbonate level, the amount of bicarbonate ions in the blood sample, 22 to 30. So anything less than 22, hypocarbia. Anything greater than 30 is hypercarbia. Now, less than 22 would be a clinical indication that your patient probably has used up all of their bicarbonate and would really be looking for a third-party acid or a metabolic acidosis. Like I said, in diagnostics, we'll talk more about these. Algorithm for interpreting arterial blood gases. You can take a look at this in the book's version, but I have most of my students do three things. First things first, what is the pH? Because then we can determine acidity or alkalinity. Second, does it have anything to do with CO2? And then third, what is their bicarb level? And from this, you can tell if it's respiratory acidosis, respiratory alkalosis, and so on. So in conclusion, This chapter discussed methods of objectively assessing patients' oxygenation and ventilation, pulse oximetry, capnography, and co-oximetry, and arterial blood gas analysis. Covered the technology, clinical applications, and limitations of each of these devices, and discussed the physiology of acid-base disorders and their effects. It is important to remember, treat the patient as a whole, not to rely solely on one device or technology in determining the paramedic's diagnosis, and develop an appropriate patient treatment plan. References for this chapter can be taken from Richard Beebe, Professional Paramedic, Volume 1, Foundations of Paramedic Care, First Edition, pages 490 to 513 of Del Mar Learning. If you have any questions concerning this chapter, feel free to contact me. My name is Roy Smith, smith@imsa.net, or 45219-7613. Thank you.